Hi, I'm Dr. Jack Cush, Executive Editor of RheumNow.com, and this is the 2nd of December 2016, and here is the RheumNow Week in Review. Um, a busy week, catching up after a really busy week at the ACR. If you haven't gone to our website and clicked on the ACR coverage, expanded ACR coverage, it's the top banner. You'll get a nice view of all the things that were presented at the ACR. You can also look at our video section, see almost over 40 videos shot during the meeting covering a lot of different aspects of the meeting. This week in the news, a report in rheumatic disease clinics in North America on the compiled safety data about tofacitinib, especially with regard to malignancy. One of the signals that came out of the FDA presentation when tofacitinib was presented was that there might be a malignancy risk that rose over time. Turns out that actually this is not true, and that expanded coverage of over 4,800 patients and several years of observation shows that the tofacitinib risk is no higher than any other drug on the market, that RA patients themselves have a higher risk of malignancy, certain ones being higher, others being lower, but nonetheless, tofacitinib is not different than any other biologic. An interesting study looked at a nested case control study of 557 RA patients compared to 1,600 RA patients who developed RA, and they looked at risk factors for developing RA, and they found that men, but not women, who had obesity or abdominal obesity or increased waistlines had a 2 to 5-fold higher risk of developing RA, especially after the age of 50. It was interesting that this was mainly seen in men more so than women. And there are different ways of looking at the data, but it does show reaffirms the data that has been seen in other cohorts, including the Norfolk Registry in England and others that showed that obesity is a risk factor for developing RA. An ACR abstract from Takeda looked at a 2-year outcome study of 157 patients treated with either placebo or febuxostat. And these are patients with early gout. That's what makes this study interesting. And they specifically looked at not just the outcome, but flare rates on these drugs in early RA patients. And they showed that for the 2-year study overall, patients who are taking febuxostat, also known as Uloric, had a significantly reduced rate of flares, 29% versus 41% in the placebo population. However, the flares were actually about the same, if not a little bit higher, in the first 6 months on febuxostat versus placebo, 17% versus 13%. This makes a little bit of sense if you think about it, because you're giving urate-lowering therapy in the treated group, and in the placebo group, you're giving nothing. In the urate-lowering therapy group, you're mobilizing a lot of uric acid and putting the patient at risk for flares, and a slightly higher rate was seen. However, with disease control and lowering of the uric acid, overall there's a lower rate of flares on the drug. So that's kind of interesting. Another interesting tweet that came from Cassie Calabrese on her website, on her Twitter feed, was that only 1 in 5, or 20% of the elderly, have actually received the shingles vaccine. Those are people who actually have the indication to receive it, but yet only 20% has. Based on this cohort analysis. It shows that, again, we're not very good at encouraging vaccinations amongst our patients, especially those who are eligible to get it. A UK study looked at, again, a nested case control of 4,500 GCA patients versus 22,000 control patients, and looked for risk factors for who would get GCA and who would not. Turns out that patients who had increasing numbers of prior infections, nonsense infections and serious infections, were at higher risk to develop giant cell arteritis. And that one of the infections that did not increase the risk necessarily was herpes zoster. We do know that there's a consequence of herpes zoster, including increased risk of stroke, but it turns out zoster is not necessarily an increased risk, a risk factor for developing GCA, whereas recurrent infections, which may alter immune responses and may make someone more at risk, is sort of a risk factor. Psoriatic arthritis sales currently almost 4.5 billion worldwide in 2015. You have to assume that most of that is made up of TNF inhibitor sales, but that's expected to grow in the next 10 years to 12.6 billion. I would expect that that's going to be the new drugs that are being added, from apremilast to secukinumab to ixekizumab, other IL-17 inhibitors, ustekinumab, Stelara also in that mix. Another nice report from the Journal of Managed Care and Specialized Pharmacy looked at a large number of RA patients and claims data, over 500,000 patients, and looked at quality measures, and the quality measures being who saw a rheumatologist, who started on a DMARD, who had screening tests done. Again, looking at over 500,000 patients and the ones who had RA, it was only shown that 58% of all RA patients have been seen by a rheumatologist. And that's about what I've been saying. We only take care of about half the patients who have rheumatoid arthritis. And again, this is in 2015. It was also shown that only 64% were given a DMARD during the time period that they looked at the patients. And lastly, looking at a screening measure being TB screening, those on biologics, only 30% actually had a TB test while on a biologic, suggesting that quality measures are important and we have room to improve on these particular measures. A UCF study that was presented at ACR looked at lupus patients. It's actually a lupus outcomes cohort of 783 patients, and they showed that patients who were within poverty range had a greater degree of organ damage versus those who were not in poverty. It was like a twofold increased risk, suggesting there's a lot of work to be done there with access and education. Yusuf Yaziki authored a poster on a Turkish cohort of 1,000 patients who, in Turkey, who had rheumatoid arthritis and were starting either Remicade, the innovator drug, or the biosimilar of that drug, Inflectra, or over there called Remsima. And it was noted, number one, that more people started their patients on Remicade than the biosimilar, and that there were fewer discontinuations on the innovator drug compared to the biosimilar, 27% versus 44%. And that when it came to switching from one to the other, there were still more switches from the biosimilar to Remicade, suggesting that there probably are a lot of preconceptions about the role of biosimilars that need to be dealt with as time goes on. There was a nice study from Podubny and other coworkers in Germany that looked at patients who prospectively who had spondyloarthritis and showed that there was a significant correlation between sacroiliitis and Xray damage and ASDAS activity, ankylosing spondylitis activity index, and that was an important correlate that could basically, if you're not doing X-rays regularly, but you are doing disease activity measures, you'll know more about your patients. It does say that maybe we should be doing more activity disease measures in our patients with spondylitis in general practice. Olga Petrina, one of our faculty, wrote a nice piece which was a review of a meta-analysis showing that statins have a role in treating osteoporosis. Based on a meta-analysis of 33 studies, they showed that the use of long-term use of statin drugs may lead to as much as a 20% decrease in bone mineral density in both the lumbar spine and the hip, but not necessarily in the femoral neck. And more interestingly, these data were largely shown for patients who were males and not so much for the females. We reported on the 21st Century Cures Act that went in front of the Congress and the House and was voted unanimously by the House for passage. It's an important bill about getting new drugs to market and has many different facets, increases funding to the NIH, some major studies. The interesting thing about this particular bill, it's been in play for almost 2 years. It's had thousands of lobbyists and almost $500 million spent on lobbying. Anyway, it passed the House. It's supposed to go to the Senate before the end of the year. We'll see what happens. I wrote an overview of rheumatology compensation and what that means to Manpower. You know, basically the average rheumatologist compensation is between $230,000 and $250,000. It's regionally different. It's different between men and women, and that's shocking. Women making a lot less than men still. Why? I don't know. And when you compare this to the manpower problem that we have, this is a big issue. The manpower problem is significant. It's estimated that 50% of rheumatologists are going to retire in the next 15 years, that being older white guys from New Jersey, maybe even other states. But as we go on, by 2030, it's estimated that almost 60% of the rheumatology workforce is going to be women. So we have a lot of issues currently. There's estimated to be 4,997, almost 5,000 practicing rheumatologists said to go down to 3,500, 3,455 by 2030. While this number goes down, there's going to be an increasing demand of 138% increasing demand for rheumatology services. This is a problem when you look at a higher number of women, a higher number of millennials who want lifestyle, a higher number of people who want to work part-time in the workplace. There's going to be a significant deficit. On top of this, even if we individually get people to go into rheumatology, get more residents and more fellows, there's not enough funded positions. And that's what the program directors are telling us. There needs to be more funding. So a significant challenge remains ahead. Look at the blogs that we have from Eric Madison on the contributions of Max Hirsch to rheumatologist, a German rheumatologist, actually a Polish Jewish rheumatologist who started the German Rheumatology Society and was father to many different movements in Europe and internationally. An impressive story written by Eric Madison. And then Lenny Calabrese, of course, another Wine the Rheumatologist article that's just spellbinding to read. That's it for this week on RheumNow.com. You can go to the website and click on the links to read more about these issues. We'll see you next week. Have a great weekend.